Mr. Rohit?
Good evening, everyone. Welcome to the 69th edition. We have a very specialized speaker, if I can say, the leading authority in this field. Next slide, please. Let me welcome Professor Dr. Tufan Pati, sir. He's from Cuttack. He's well known to all of us. Sir, please, apologies for not reading out your slides. Sir, over to you with just the words that the meeting will be recorded. The participants are expected to be on the mute mode. They can put their questions in the chat box, which will be put to the speaker later on. Sir, over to you.
Mr. PS, thank you very much, Adim. Mr. Patel, you unmute everyone. Only let faculties, you mute everyone, let faculties unmute them. Otherwise, there is some sign. So, thank you. So, proceed. So, as we go to this edition of our Thursday Musings, I have the formal duty to say 2 lines about Dr. Amrit Patjoshi, who is not here today because he is also ill, and Dr. Alim Siddiqui. They are the vibrant moderators of Thursday Musing over almost more than a year, and I have got a lot of compliments for them. And now I shall move on to introduce our allies chairpersons. Dr. Prasenjit Ghosh, who is like my younger brother, is a very dynamic young psychiatrist from Silchar. He's assistant professor of psychiatry. He did his MD psychiatry in 2003 and assistant professor since 2011, nodal officer of OSTC, and he has got 48 publications and 20 citations to his credit. He's assistant editor of IJPP and assistant editor of Indian Journal of Social Psychiatry. Welcome, Dr. Prasenjit.
Thank you, sir. Thank you. Thank you.
And we have got Dr. Pankaj Kumar, the experienced consultant psychiatrist, the director and chairman of the Healers Psychiatry Center and founder of the Healers Institute of De-Addiction and Psychiatry in New Delhi. He has got more than 20 years of experience in the field of medicine and clinical research as well as teaching. Worked as an associate professor at Saraswati Institute of Medical Science and at HOD Psychiatry at Goldfield Medical College and Hospital. He received a number of awards and appreciation for his extraordinary contribution in psychiatry field and social works. The previous slide, please, Pankaj Kumar received, and he's a visiting consultant of Sir Gangaram Hospital and Max Super Specialty Hospital and worked at the senior psychiatrist in the Hospital of Delhi, GTB, and UCFH. He's associated with a number of professional and social organizations, with the General Secretary of DPS and assistant editor of Delhi Psychiatry Journal. With this, I welcome Dr. Pankaj Kumar and also Dr. Prasenjit Ghosh, and the meeting is over to the chairpersons. So I take leave now till we come for the discussions. The meeting is yours. The stage is yours.
Thank you, Tufan sir. I request Dr. Pankaj Kumar to introduce the speaker.
Hello. Yeah. Good evening. Good evening to all of you. And thank you, Tufan Pati sir, for your kind words. And Dr. Alim sir, Dr. Patjoshi sir, for having me over here on this esteemed Thursday Musings. And today, without doing much ado, I would like to welcome our today's speaker, our star speaker, Dr. Ravi Gupta, is a professor in Rishikesh AIIMS. He's done his MD, PhD, and he is certified sleep physician in World Sleep Federation. He's leading authority in sleep medicine. I would say, in fact, he's one of the pioneers in today's medicine world. Additional professor, Department of Psychiatry and Division of Sleep Medicine, AIIMS Rishikesh. And my associate, Dr. Ravi Gupta, sir, is quite long. He was SR in GTB, USNS Delhi. He left his seat. I was the one to take over that seat. Then he went to Himalayan Institute as a consultant there. I did my UG from there. And so, sir's association is quite long with me. And that is quite dear and near to my heart also. So it's really happy to be sharing session with sir. So thank you very much, sir. And I would like my co-chairperson, to please introduce the topic of today. Thank you, sir.
Thank you, Dr. Pankaj Kumar, sir. Today's topic is sleep hygiene and some myths about benzodiazepine. Sleep hygiene, we all know that it's about our habits and practices that are conducive to good sleep regularly. And we would like to have good sleep without the help of medicines. And these habits and tips, I am very much sure that Ravi Gupta sir will be talking very in great details as an expert. But I would like to say that consistency is very important. One should maintain a consistent sleep schedule, avoid electronic gadgets before bedtime, restrict caffeine, and other things. And benzodiazepines, we all know that there are lots of researchers that cognitive impairment is very strongly associated with benzodiazepine intake, and there are even reports of early mortality. So, with these very few words, I would like to invite our esteemed speaker of today, tonight, Dr. Ravi Gupta sir, to start his deliberation. Thank you.
Thank you, Chairperson. And I'm also thankful to Dr. Aleem and Tufan Pati sir for having me here. Dr. Prasanjit mentioned something about the benzos, and I would like to differ with the comments that he has made. Anyway, that's a very small kind of talk that we will be having today. So basically, for today's discussion, it's basically the sleep hygiene and how can we transform this sleep hygiene from theory to practice. So that will be our main content of the presentation, and then we will discuss about this. So as Dr. Ghosh has already mentioned, that sleep hygiene actually means that one needs to learn some habits which are sleep promoting, and the person is encouraged to follow those habits. So the issue is here, these two things show that one is the learning. That means first the person should be ready to learn. And as you will see, that is one of the major obstacles for the sleep hygiene. Secondly, regularly following that's another an obstacle. So these two obstacles, they actually come hand in hand the moment we talk about the sleep hygiene practices. So it's easier said than done. Now, what are the common sleep hygiene instructions? So this is a slide that I have taken from the CDC, and it simply says, as Dr. Ghosh has already mentioned, that one has to maintain the consistent bedtime and wake time, including the weekends. One has to improve the environment where one is sleeping so that the chances of falling asleep and maintaining the sleep are higher or greater. Then one has to remove any kind of distractions from the bedroom. Fourth, we have to avoid any kind of stimulant or the substances that can disrupt one way or the other way the sleep before the bedtime. And fifth, do some exercise, because there have been number of papers which suggest that exercise actually helps to improve the sleep. Now, the issue is, one of the major question is, do we really know about the sleep hygiene instructions? So this was a survey, online survey of the physicians which was conducted. And Carney is one of the major figures in the field of insomnia, belongs to UK. And so the crux of the paper was that most of the physicians, they felt that only sleep hygiene instructions, they are a good efficacy as a standalone treatment for insomnia. So that's actually a myth, and this is not true, and that we'll see in the subsequent slides. Secondly, what are the constituents of sleep hygiene that we have discussed in the previous slide? But most of the physicians that they have surveyed, they reported that some of the other instructions, other than what we have discussed in the previous slide, they are also the part of the sleep hygiene education. But actually, those instructions, they are basically the part of stimulus control therapy. And same way, the literature regarding the sleep hygiene education and its effects on the insomnia has also been suffered from these kind of limitations. And that is the reason that we have heterogeneous data regarding its efficacy, applicability, adherence, and other things. Now, how do we contaminate the sleep hygiene instructions? So sleep hygiene only talks about the consistency of the bedtime and the wake time. It only talks about the medications or the substances that needs to be avoided or to be taken. It talks about the exercise. But at the same time, if you look at various websites, even the professional websites, for example, National Sleep Foundation website, then even American Academy of Sleep Medicine website, you will find that they do not mention exactly the sleep hygiene, rather they mention tips to good sleep. And in tips to good sleep, they also include certain instructions which are basically the part of a stimulus control therapy. For example, when to go to bed is one of the major part for the stimulus control therapy. So in SCT, we usually say that you go to bed only when you are feeling sleepy, and that's not the part of the original sleep hygiene instructions. But unfortunately, this has often been suggested as a part of sleep hygiene education to the patients. Then secondly, SCT or stimulus control therapy clearly mentions that bed should be reserved only for the sleep and the sex, and no other kind of activity should be performed in the bed, so as to reduce the association between the insomnia or wakefulness and the bed. Then third part that SCT talks about is what should one do when one is not able to fall asleep, or when one wakes up during the middle of the night and is not able to fall asleep in again 10 to 15 minutes. So that's again often mentioned as a part of the sleep hygiene education, but that's actually basically the component of the SCT. Then when to wake up, again, that's a part of the stimulus control therapy. And unfortunately, the sleep hygiene instructions, they always mention that you should wake up at early in the morning or something like that. Then sleep hygiene instructions also include the napping. Now these last two, when to wake up and the napping, these basically, these two instructions, they decide the sleep pressure. Sleep pressure means it simply says that longer we are awake, higher the sleep pressure, so greater are the chances to fall asleep. If we talk biochemically, then you will find that the sleep pressure more or less correlates with the amount of adenosine in the cortical areas, especially the frontal and the parietal cortical areas. And that is the reason when we consume caffeinated beverages, including coffee, which is an antagonist for the adenosine, so we feel alert and awake. So these are basically the parts of the stimulus control therapy and not the sleep hygiene. Now, this is a very interesting paper which reviews the different sleep hygiene instructions and different components and their validity and efficacy. So we usually say in the sleep hygiene instruction that one should not consume coffee or caffeine close to the bedtime. So there is a complete no, do not consume. We do not say that do not, you may consume or you may consume half a cup or something like that. Now this is a good instruction because we know that there is a dose effect. So if the consumption is higher, if we have the higher dose of caffeine, then the chances of staying awake are higher. But there are certain issues with this instruction. For example, even I remember the time during my adolescence when one of my friend invited me for the late night studies. I was in 11th class. So we prepared a cup of some tea and for jug full of the tea. So we started studying, and I am an early sleeper. So by 12 o'clock, I had 8 cups of the tea in my stomach and I was sleeping. So that sensitivity to the caffeine, it varies between individuals. If a person is not sensitive to caffeine, this instruction should not be given. Second is the timing. But we do not have any specified research which suggests that 6 hours before the bedtime or 4 hours before the bedtime, and also the dose, that 2 cups of the caffeine or 2 cups of coffee or maybe anything in that manner is deleterious to falling asleep or maintaining the sleep. So this is again an area where we are not sure whether the caffeine should actually be restricted as a sleep hygiene instructions. Then certain people who are habitual users of caffeine, if we ask them to discontinue caffeine, whether they will benefit, research does not show any evidence which suggests that they fall asleep early. So data is not available. Similarly, the case is with the nicotine. Again, we say that nicotine is an stimulant and should be avoided at any cost. But the problem is in the patients who are dependent on the nicotine, the acute withdrawal from the nicotine actually worsens the sleep. And that can actually have a negative effect. Secondly, there is no data or very limited low quality data which shows that what are the long-term benefits of complete abstinence from the nicotine on the sleep. Regarding alcohol, again, we know that if somebody is consuming the alcohol in small amounts close to the bedtime, then it actually helps the person to fall asleep, especially if the person is non-dependent. But problem is, even in the people who are dependent, if you ask them to remain abstinent with the alcohol, and we all know that they become sleepless. So that actually worsens the sleep. Now the question is, okay, doc, I'll not be drinking after 8 p.m. because I go to bed at 10. But what if I take say a peg or maybe a couple of pegs around 4 o'clock, 5 o'clock? And many of the patients who are also who consume alcohol, they also smoke or consume tobacco in one or the other way. Now, what is the combined effect of these two substances? Because one is the CNS depressant and the other is the stimulant. This is again not known. We usually say that exercise, it increases the endorphins in the brain, increases the wakefulness, alertness. So one should not be engaged into the strenuous exercise near the bedtime. But we all know that many of us and our own colleagues, friends, patients, they go to gym late in the evening after coming from the office. So, and on the other hand, we also say that if somebody is tired, physically tired, that increases the sleep. So acutely, if you are indulged in the heavy exercise, that actually on one hand is supposed to increase the sleep, and on the other hand is supposed to increase the arousal. So the issue is the effect of the exercise on the sleep, it varies with the mode, intensity, duration, and the timing. And literature regarding these different issues is scarce. Second issue is what happens in the habitual evening the people who are doing the exercise, heavy exercise, habitually in the late evening. For example, the person who are going to gym in the late in the evening, whether they do develop the tolerance to the arousal effect of the exercise, that is not known. Then effects can vary across gender, age, and the fitness. And again, the literature in this regard is scarce. Other thing we talk about many a times in sleep hygiene instruction is the relaxation therapy, which is again clearly not the part of the sleep hygiene, but we say that one should not be stressed when one is going to the bed, because the stress enhances the arousal. But the problem is the reactivity to the stress is again individualized. A person in the stress, even in tremendous stress, may fall asleep, have a good quality sleep with normal duration, can appear healthy, everything except that he is having the stress, and that he talks when you ask him whether the person is stressed or not. So that reactivity to stress is again highly individualized, and that is the reason we also see that everybody who is stressed does not develop psychiatric disorders similar to the insomnia. Then coming to the noise, we always say that you should not have any noise near the bedroom. Well, prima facie, it appears that yes, if there is a loud noise, that will make the falling asleep or maintaining the sleep difficult. But many of us who are having good sleep, they can sleep even in the most of, I mean, in a noisy environment. So, and also the effect of the noise is mediated by the continuity of the sound, the type of the sound. The type means the pitch of the sound, relevance of the sound to the person. We all know that we all wake up when somebody calls our name, even when we are deep asleep. And again, there is an individual sensitivity to the noise effect. We do not know whether if a person is staying continuously in a noisy environment, does he develop the habituation? So that's again an area which we are not sure. Then we talk about the regularity of sleep-wake schedule. Again, we all know that sleep is also a kind of learned behavior, like food intake. So if we are having a regular sleep-wake schedule, then we usually feel sleepy at a particular time. So there is a conditioning, but the people, they again have individual reactivity to alteration in the sleep-wake schedule. In some people, a slight alteration can disrupt their sleep. In others, it does not. And we do not have any scientific data, which is robust to say that a regular sleep-wake schedule actually increase or promotes the sleep. Because most of the data which is available is subjective, which is having a recall bias. Again, there could be a difference on the weekdays as well as the weekend because of, and again, this effect is mediated by a number of other factors: the total sleep duration, the timing of the sleep, the stress that one is having. So the strength of evidence are quite low. And coming to the napping, we all know napping reduces the homeostatic drive, but how much? And is it clinically meaningful? We all know, many of us, we sleep late in the evening and then again we fall asleep early in the night. So, and again, napping is a kind of having socio-cultural acceptance in the napping is common in the Asian countries, which are having the warm climate. So what happens if you ask the people who are habitual nappers to avoid their naps? Whether this further increases their sleep quality and sleep duration, this we do not know. Whether it does have some homeostatic effect to increase the sleep pressure, and these patients who are habitual nappers, if they are not allowed to take nap early in the say in the afternoon, so whether they feel sleepy earlier than their usual bedtime, that is again we do not know. And thirdly, the effect of the nap depends upon the duration, timing, as well as quality of the nap. So there are multiple factors which influence the overall recommendation of the sleep hygiene on the nighttime sleep. And the literature regarding those factors is limited. Now, this knowledge, we should have the knowledge regarding sleep hygiene instructions. Why? So this was a study which was done in 2005, and in this survey they included the 18 to 65-year-old individuals, and this was a cohort which was the part of some other study, and they found the persons who were having insomnia and those who were not having insomnia. And they compared the sleep hygiene practices among these two, between these two groups, and they found that the person who were having insomnia, they were having poorer sleep hygiene, especially with regards to the increase in smoking and the alcohol consumption close to the bedtimes. And they had more number of naps in the afternoon, but regarding other factors of the sleep hygiene, the data was not available. So this shows that the sleep hygiene differs between the patients who are having insomnia and those are normal sleepers. So this knowledge is important so that we can train our patient. Now, this is a systematic review which was published last year, and it looked at the sleep hygiene practices in shift workers. So it included 16 studies. And we all know that the shift worker, they actually cannot follow the sleep hygiene because of their constantly changing shifts. So in shift workers, there was a high prevalence of daytime napping, which is again something contradictory to the sleep hygiene education. They were trying to consume caffeine to stay awake. So they were actually using these techniques, napping, daytime napping, as well as nighttime caffeine consumption to allay the fatigue. So in these workers, whether it is more important to allay the fatigue or whether it's more important to follow the sleep hygiene instructions, this is again not known, and the future research is required in this area. Now, the question is, there is contradictory research which is available. There is another study which was published in again 2006. So this had actually two different groups, one from Boston, another from, I think, Bethesda. I'm not really sure about the city. So they had a total of 430 participants, and they all were elderly. This is contrary to the previous study where most of the participants were young adults. And these participants were recruited through the advertisement, and they were given sleep diary for two weeks. And they were asked to recall their consumption of the alcohol, caffeine, and nicotine close to the bedtime. And they were also asked about whether they are having insomnia or not. So based on the data, they were divided into four groups. One are the non-complainer, that means they did not complain about insomnia, and sleep diary did not show any insomnia. Then there were the groups who complained that they had insomnia subjectively, but sleep diary did not show that they have insomnia. Then third is non-complainer, but having insomnia. And fourth are the subjective complaints of insomnia along with objective evidence of the insomnia through the sleep diary. And they looked at the sleep hygiene practices among these four groups, and very surprisingly, the sleep hygiene practices were comparable across four groups. So this data shows that at least in the elderly, the sleep hygiene practices, they do not contribute to the insomnia occurrence or the persistence. When it comes to the whether we should use the sleep hygiene practices for the management of insomnia, again, the evidence is limited and it is virtually ineffective as monotherapy. But when it is combined with the other models of the CBTI, that is the sleep restriction therapy, relaxation therapy, cognitive restructuring, and the stimulus control therapy, then it becomes effective. Now the issue is whether it becomes effective or a multitude of these therapies, they are actually having a positive effect on the improvement of sleep. This is again something which is again not known. So this was again a meta-analysis which looked at the effectiveness of the sleep hygiene education versus CBTI and sleep hygiene education versus mindfulness. So this meta-analysis found that the people, when they were given sleep hygiene education, their sleep was better after the sleep hygiene education than before the sleep hygiene education, but the effect size was small to medium. Secondly, there was no change in the objective measures, which was measured through the actigraphy data. So only subjectively the people said, yes, my sleep has improved. But overall, if we look at the effect of the sleep hygiene education alone, it was much lesser than the multimodal CBTI. And the effect size was medium to large, which shows that the finding was robust. But in this meta-analysis, there was no data regarding the acceptability, adherence, and cost effectiveness of sleep hygiene education. And these are important issues to be discussed that we will discuss in later slides. Now, these are the most recent guidelines published by the American Academy of Sleep Medicine. And they found that only 3 RCTs are available for the sleep hygiene education. And in these RCTs, the remission rates are not reported. When it comes to the response to the insomnia, there is a response, the SHE, the sleep hygiene education, it improves the response in the insomnia compared to the control situation, that is the wait listing, but there is a risk of bias. And individual sleep variables, if we talk about, so if we look at the data, if effect of the sleep hygiene education on sleep quality, there is no data. Regarding sleep latency, that means the time to fall asleep after lying down on the bed with an intention to fall asleep. The effect size is not clinically significant and there is a risk of bias. Regarding the wake after sleep onset, the time spent awake between the first sleep and before the waking up, again, that is not clinically significant and there is a risk of bias. So overall, the committee mentioned that the overall quality of the evidence is low. There is a lot of imprecision and risk of the bias. The benefits are comparable to the control interventions. Control interventions means just the exercise or wait listing. And if you are suggesting the sleep hygiene education as a monotherapy to your patient with insomnia, then you are actually delaying the optimal therapies, that is the multimodal CBTI, which is available, or the pharmacotherapy, which is available to treat the insomnia. And that actually leads to the progression of disease. And we all know that if longer the insomnia remains untreated, through the process of kindling, it becomes resistant to treatment. Now, coming to the cost analysis, again, the same paper they mentioned that any cost for a therapy which is ineffective should be considered as expensive. As we have already discussed, there is no data regarding the acceptance of the sleep hygiene education by the patients and adherence to it. So in total, they recommend, these guidelines recommend that sleep hygiene education should not be used as a standalone therapy for the patients who are suffering from clinical insomnia. The question is where it can help. If we talk about the public, so if you are giving them the sleep hygiene education instructions who are not suffering from insomnia, then there could be some improvement in the sleep of these patients, as you'll see in a couple of subsequent slides. So there actually, there it can improve the sleep because the prevalence of the insomnia symptoms is greater than the prevalence of insomnia disorder. And the issue is, again, as we have discussed in the previous slides, that there are different definitions for the sleep hygiene education. There are inconsistent instructions which were given to the patients, and the method of implementation is again varied. Some people, they just convey it verbally. Some people, they give the flyer. Some people, they ask the patient to go to a particular website. So there are different ways to how do we deliver the sleep hygiene education. And again, this is an open area for the research in the future. Now, this is a good study which found that if you are giving the sleep hygiene education to the young adolescents in different sessions, then it actually improves the sleep pattern, lower the caffeine consumption, and the improve also the self-efficacy. Self-efficacy means that yes, I can control my sleep and the wakefulness. So that as self-efficacy increases in the young adolescents who are healthy, not having insomnia. Similar results nearly were found in the undergraduate students, but in this study, there was no change in the knowledge and the self-efficacy and the sleep quality after the sleep hygiene instructions. So again, whether the sleep hygiene education instructions they can improve the sleep or not, this is again a big question. This was a small study which looked at the effect of the sleep hygiene education in the working women, and they found that sleep hygiene education can improve the sleep quality. In elite athletes, this study, they gave the athletes actigraphy, which recorded the sleep pattern and sleep wake schedule for 1 week. And then on day 8, they were given the sleep hygiene education. And again, they were allowed to wear the actigraphy. And in the sleep hygiene education in this study, they talked about the importance of the sleep. They talked about the sleep wake schedule, regularity, maintenance. They talked about the how should be the environment of this where we are sleeping. They talked about the stimulants and alcohol that can influence the sleep. They talked about the gadgets that we are using and also the relaxation technique. Again, relaxation is not the part of the original sleep hygiene education. And they found that the sleep hygiene education in these elite athletes, it improved the wake episode duration and also the wake variance. But the other indices like sleep quality, this sleep efficiency, the sleep onset latency did not improve. Now coming to the acceptability by the patients regarding sleep hygiene education. We all know by our clinical experience that even, we really try hard with our patients to convince them to follow non-pharmacological methods, but only a small proportion of them, they really give an ear to our what we are saying. And only a small part of those who give an ear to it, they actually follow the instructions consistently. Now, this is the clinical, this is what we were talking about on the basis of the clinical experience. When it comes to the scientific data, so this study was done in 2019. So they included 27 adolescents who were well versed with the use of the app. So they were asked to use any of the two apps which were having the sleep hygiene instructions. And after 2 weeks, they were indulged into the focus group discussions regarding various issues about the adequacy, efficacy, and they found that the most of the adolescents, they were reluctant to follow the sleep hygiene instructions, especially on the weekends, because they thought that that was the time for partying. They were really not happy to do away with the gadgets near the bedtime. Many of them, they found that sleep hygiene instructions are difficult to follow because of the academic demands, and lack of motivation to follow the sleep hygiene instructions was again pervasive. Now, this is another paper which talks about the predictors of the adherence to CBTI as a whole. And the same thing also applies to the sleep hygiene education instructions. So what are the factors that are the barriers to the adherence? So the people who are suffering from anxiety and depression, they do not follow the CBTI. So they are less likely to follow even the sleep hygiene education. People are who feel boredom with these kind of instructions, who are feeling discomfort or annoyed with these kind of structured sleep wake schedule, they do not follow it. People who find it difficult to assimilate in the daily life, and who find that they cannot adapt their daily life schedule to the sleep hygiene instructions, they do not follow it. But the people who are having positive attitude, who think that it is relevant, who expect that yes, this can improve their sleep, who feels that they are having they can have a control over their sleep and wakes thing, and those who are having good past experience with the non-pharmacological therapy are likely to be adherent to the sleep hygiene education instructions. So in conclusion, sleep hygiene education is an effective therapy as a monotherapy especially for the patients suffering from clinical insomnia. It may improve in certain non-clinical settings, but not all, and the data again is contradictory, limited. And there are multiple issues with the sleep hygiene education instructions, and many of them are the major of them are the acceptance, adherence, and the limited research about the different components of the sleep hygiene education. With this, I rest my case, and I thank all of you for your patient listening. Thank you very much.
Thank you so much, sir. Thank you so much, sir. Any opening comments from the chairpersons? Hello. Hello. Am I audible? Hello.
Yes, you are audible.
Yeah, if chairpersons would like to have some opening comments. Meanwhile, Ravi boss, what exactly is sleep hygiene in few words?
Well, sleep hygiene, if we talk about, as I mentioned, that's the original sleep hygiene instructions are mentioned in the CDC guideline, and they only talk about when to sleep. And even they do not talk about when to sleep, they talk about the regularity of the sleep wake schedule. They talk about what is to be avoided close to the bedtime. Okay, and they also talk about the avoiding the naps during the day, so as to we have the higher sleep pressure when we go to bed. So for the benefit, I think I'll share the original slide again.
Yes, sir.
Yeah. So these are basically the sleep hygiene instructions, original sleep hygiene instructions without any contamination.
So original means they were given by CDC?
Not CDC. These were given by, I think, Kleitman in 1959.
Okay. So does this, how much is it endorsed by the Sleep Medicine Society, that international body?
So they are the part of the multimodal CBTI. So there is no doubt about it.
Okay. Okay, sir. What about this use of screens? This night mode and all these things are there. So many people are asking you about this screen use.
It's just again, Alim bhai, it's individual reactivity. Look, the issue is, I think we too easily generalize everything. So if you look at most of the recent papers, especially the meta-analysis, they always talk about that sleep hygiene instructions are to be individualized. And we should take into account this reactivity to different kinds of say instructions that we have already talked about. For example, caffeine, nicotine, alcohol, stress, other things. Okay, And then we should also try to adapt it to the person's sleep-wake schedule, his academic, his professional schedule. So if we give a blanket kind of instruction that nobody is going to follow, it needs to be individualized considering what kind of patient are we dealing with.
Sure. Thank you, boss. There is a comment that we have not yet discussed about benzodiazepine myths. We'll come to that. Dr. Ravi has all the knowledge that we need. We have kept it for the discussion portion. Those who want to ask questions, please put in the chat box. We cannot invite everyone because we have 250 participants.
There are multiple questions I can see in the chat box.
Yeah.
So there is Dr. Amandeep. Reactivity to stress may be different from different individuals, but we need to see what happens in most cases. Very true. Does stress lead to deterioration in
one more question? They were asking, what about child sleep patterns, sir? They're asking quite frequently.
I'm sorry, bhai.
So what about child sleep patterns, sir? They're asking it quite frequently. Child sleep pattern.
Okay. So the issue is, again, when it comes to the sleep pattern, we need to understand two major issues. First, the amount and the architecture of the sleep. That means the relative the proportion of the REM versus non-REM sleep. It is a function of the age. So we all know that the infants, they sleep for 20 to 22 hours a day, and as the child grows, becomes a toddler, then the total sleep time reduces to somewhere around 18 hours, 16 hours. So by the adolescence, most of the children or the adolescents, they acquire the sleep time, which remains stable for another 20 years. And then again, the total sleep time start deteriorating after the age of 40. That is one thing. So sleep timing is one thing. Second issue is regarding this. Second issue is that there is again individual variation. Many of us are long sleeper. Many of us are short sleeper. Many of us, and most of us, we fall in that bell-shaped curve. So if I talk about the bell-shaped curve, most of the people, they require 6 to 8 hours of sleep. Most of the people, or else I can say that we are designed by the nature to go to bed early in the evening and wake up early in the morning, as our ancestors used to do. And still the people who are fortunate enough that they do not have any kind of the electricity or electronic gadget, they follow. So again, it is very difficult to say what kind of sleep pattern a child should follow. This again depends upon the age. But if I generalize is early to bed, early to rise. And sleep that much. And what is more important, that you should have the amount of the sleep, the quality of the sleep, and timing of the sleep, which allows you to function properly when you are awake.
Sir, there is a question regarding what kind of advice you will give to a person who has regular shift duty.
Sir, shift workers, around 5% of them, they have shift worker disorder. So they are having difficulty with their sleep-wake schedule. And 95% of the workers, they actually adapt well to the shift, provided that the shifts are properly aligned. So if I talk about from the physiological point of view, the shift should start from morning, then should go to evening, then to the night. Unfortunately, in most of the industries in India, and even in the hospitals, the shift goes other way around. The person goes from the night to evening and then to morning, which is again contradictory to our regular biorhythm of the suprachiasmatic nucleus.
Thank you.
Okay.
And second, how much time is given between the two schedules? Look, again, we adapt to a particular sleep wake schedule. If you start staying awake till 2 o'clock in the night, after 4 days, you will not be able to fall asleep before 2 o'clock. So that's an adaptability of your brain. And
Sir, you can stop the slide share.
I'm sorry?
Sir, you can stop the slide share, and please make Dr. Prosenjit as co-host. I think he was not able to unmute himself.
Yes, yes.
Yeah.
So how much time is given between the 2 shifts? That is again one important issue. Because during that time, the person has the time to adapt himself, realign with the coming shift.
Yes.
Okay. Okay.
Ravi sir, we
Thank
have
you,
one more
Thank
interesting
you.
question. One have asked, any special direction for sleep, sir?
I'm sorry, whenever?
Sir, any direction to good sleep? Any direction to good sleep?
Direction to good sleep is, again, follow the sleep hygiene instructions in general if you are not having any sleep disorder.
No, sir, I think they are asking any east, west, like that direction.
Oh, no, I'm not aware of that. That could be from some kind of Sengfui or these kind of techniques.
Sir.
Okay, Ravi boss, we'll come back to the questions if you allow. We want to talk about the benzodiazepine myths. We have to give benzodiazepine. We have to not give benzodiazepine. How harmful? How addicting? Because in my experience, I have now started favoring benzodiazepines.
Alim, you are opening the Pandora's box. Well, I would first say I am a huge fan of benzos, and I liberally prescribe benzos to my patients, of course, with an instruction that they can discontinue it on any point of time. I would always say you can play with the dose, not on the incremental side, but on the reduction side. And so if we talk about the benzodiazepine dependence, there is most of the work which was done by the Thomas Roth and T. Rohrs, and they mention in some papers that most of the data that we talk about, the tolerance of the benzos, it comes only from the animal studies. There is no human data so far which suggests that the tolerance to benzos develop in human. And we all are coming across number of patients who are consuming 0.25 milligram of alprazolam for 20 years. And they are sleeping well. They do not need to increase the dose. So that incremental dosing is seen only in a small subset of patients who are already suffering from other kind of addictive disorders. And this is, I'm talking about the scientific data, not my own perception. And I can share the data in any of the groups if they want. So this low dose benzodiazepine dependence, when we talk about, I think again, the data is not clear. I had a clear discussion with number of addiction specialists. They themselves could not find any data to support that there is something known as low dose benzodiazepine dependence, except that we say that person has become dependent. Now, when such are the state, I always ask my patient, say, if I am hypertensive, I am taking antihypertensives for 2 years, am I become habitual to that? The moment I do not take it, my blood pressure will rise. You are having anxiety, you are having insomnia, it is a chronic problem. You are taking 0.25 milligram of clonazepam. The moment you do not take, it will again, there will be an upsurge of the anxiety or the insomnia. So this low dose, just by having our own conceptions, this is what I personally feel. People, people can disagree with me, but this is what, based on my reading of the scientific literature, that we cannot just say deprive somebody of the benefits that one can get with the benzos just because we think that these are addictive medications. But yes, there is a subset of patients, as I already mentioned, who are already alcohol dependent, who are opioid dependent. These two groups, they are likely to increase the dose of the benzos. So we have to be very careful with the benzos prescription in these two groups.
Sir, what I'm gathering, yes, sir, what I'm gathering through your presentation is when central theme that is running, that is everyone is different.
Yes.
So some are predisposed to benzos addiction. Some will have reaction to coffee. Exercise will affect someone. Some will not. So this labeling of everyone as this homogeneous group, I think that is one of the major issues that we are handling here.
I have a number of patients who come to me and they are not taking benzos for 3 months, 6 months, even when it is available in their prescription, because I always write it.
Okay.
And also I put a note that person is not taking for past 6 months, for 3 months. So I think all of us, we should try to come over our misconceptions, and even we should try to collect some data. I mean, if every one of us contribute just 50 patients, we'll be having the largest data in the world.
Sir, I can give you some data on long acting if you plan a study.
Of course.
Because, sir, this short acting versus long acting version, is there a difference in addiction potential?
There is no data. No scientific data talks about it.
Okay.
The only problem is if a person is having, say, a person is having anxiety or the insomnia, you are giving him short-acting medication. What will happen after 4 hours or 5 hours? The effect will deteriorate, and the symptoms will increase. So he'll pop up another pill. What do we see in Parkinson's? We start with the levodopa BD doses, then we go to TDS doses, and then to QID doses.
Exactly.
So that just depends upon the progression of illness. And also the say pharmacological properties of the molecule that you are using.
Okay, there is a question by Parmar Boss. What about the addictive potential of benzodiazepines? Sir, we are not advocating the use of benzos. We are trying to counter the myths, the bad press that is there. Benzos are good, benzos are bad. If you use judiciously, then there will be a better molecule. So, किस में use करना है, किस में नहीं करना है, that we have to identify. Ravi sir, any comments on this?
Of course, I think if we are not providing the help of the benzos to a person who is suffering from insomnia or anxiety, I think that's a crime.
Okay. And benzos,
as long as the person requires it. Again,
sure.
As long as the person requires it.
Sure. But you should be aware that benzos do have their own problems. So
every medicine has its own problem.
Yes.
See, there is a meta-analysis which was published in 2019. I can share the meta-analysis with all of you. That meta-analysis talks about the adverse effects of the benzos, as talked about the risk of fall, dementia, death. And it simply says that the risk of fall is higher with SSRIs and antipsychotics compared to benzos.
Okay.
The problem is we are not looking at the studies where the benzos were prescribed. Benzos are usually prescribed to whom the people are suffering from insomnia, who are likely to be old, who are likely to have other medical disorders.
Okay.
So of course, their mortality rate will be higher than the general population.
Okay.
And the dose will go higher in those who are having the greater pathology.
And sir, your comments on non-benzodiazepines like zolpidem, etc.
Again, there is both kind of literature I have come across. Some of the literature says that the Z drugs, they are not habit forming, contrary to benzos again. And some of the literature says that even Z drugs are habit forming. So again, the issue is if you are using a particular molecule judiciously in a patient who requires it in the correct dosage for the optimal period, I think you are doing justice with the patient.
Okay. Sir, then there is a question about Qutipin and trazodone.
If I talk about the ASM guidelines, which were published in 2017, They simply says that the harms associated with trazodone for the management of insomnia are greater than the benefits. So trazodone, the recommendation is trazodone should not be prescribed to patients with insomnia unless you're prescribing it for some other reason. For example, chronic insomnia comorbid with major depressive disorder. And regarding quetiapine, we do not have any data so far for the safety. But again, we all know the kinds of movement disorders and the other things that these medications can produce. So those are definitely safer alternatives to the quetiapine.
So what about 12.5 mg clozapine?
Again, the same thing. We have to look at the pharmacological profile, and I think that will help us. Clozapine, clozapine is a good choice provided you are having a person who is having insomnia associated with psychosis. Given quetiapine is good in that case. I would not like to prescribe one molecule for one antipsychotic and one benzo. I would also like to take advantage of the adverse effects of the molecule to induce the sleep.
It's a question by Dr. Fabian. Sleep-inducing music, relaxing music, mantras are available on YouTube. So what are your comments on this? Recommend or not?
I did not come across any kind of scientific literature which has assessed it, but yes, a relaxation. If we talk about the different models of the insomnia, so one of the model is AA model. So that model talks about that the people who are having insomnia, they have selective attention bias. So when they go to bed, their attention comes to whether they will be able to fall asleep or not. And that stress actually starts their stress circuitry. So they become more alert. They become alert, so they are not able to fall asleep again. And that usually further worsens the stress. So that's a vicious cycle that starts. So if you're using any kind of distraction technique, and if you have a belief in that, the most important part is you should have a belief that yes, this is going to work. And that will work.
Okay. Okay. Dr. Pfizer has a very interesting question. Is there a basic equation like 1 hour sleep for every 2 hours awake?
No, as of now, we don't.
So on a related note, suppose a patient is having problems at sleep at night, but he's taking rest in the day. Many patients I ask, do you sleep in the day? So I say, no. Do you rest in the day? Yes, 5 hours. So how many hours of rest in the day counters the night sleep? Is there any equation on that?
No data is available regarding the rest.
Your experience?
Well, as long as the person is awake, I don't think so there would be any problem. If the person is awake and using his brain, then the adenosine gets accumulating. So that will actually increase the sleep pressure. The only problem was the effect of the exercise and the tiredness and the fatigue will go away in that case.
Okay. Paresh Boss asks, any home remedy, Ayurvedic medication can help induce and maintain sleep, role of tryptophan in milk, any study, any comments on this angle?
Sir, there is no data regarding tryptophan, and again, the same guidelines, pharmacological therapies for management of insomnia by American Academy of Sleep Medicine. They say a big no to this. There are some papers regarding Rauwolfia serpentina, but again, we have to look at the benefit versus the harm ratio.
Okay. There is a question 2 times. How much hours of sleep is required for a 1-year-old child?
1-year-old child. Sir, usually if we look at the data from the National Sleep Foundation US, they usually say that 1-year-old child should have at least 18 to 20 hours of sleep. So, but again, that's a range. And there is an inter-individual variation depending upon number of other factors.
Okay. Dr. Pramila asked, management of sleep state misperception.
Most difficult condition to treat. Most difficult condition to treat. But yes, in our experience, clinical data, whatever we are having, some patients, It's not published data. So benzos, they actually help. And only benzos help. We have tried some other medications and they are not helpful.
Which sleeping medication interferes least with sleep architecture?
Sir, there is, at least to my knowledge, I don't have any information that which interferes least with the sleep architecture. I think every molecule has its own way to affect the sleep architecture. But again, the issue is, sir, we are not really interested in the sleep architecture as long as the nighttime sleep is healthy. Healthy means in duration, quality, and the timing. And the person feels fresh in the morning. So we should not worry much about the sleep architecture, whether it's increasing the REM or the non-REM or the stage N1 or stage N2. We should not worry about that. More or less, most of the medication, they have almost similar kind of effects.
And sir, melatonin, role of melatonin?
Melatonin is not a hypnotic agent. It's a chronobiotic agent. So it actually regularizes, it tells your brain when to fall asleep.
Okay. So what is the proper dose of melatonin? I think we have been underdosing melatonin.
Yes, there is no proper dose. No data is available regarding the proper dose. One of the reason is that melatonin is available as OTC in the Western countries as a food supplement. So there is no proper data regarding the regarding melatonin that and the pills, they come in 3 milligram, 5 milligram, 10 milligram doses in India.
Dr. Sheta asks, is the afternoon nap healthy?
Again, it's a big question. There are multiple systematic reviews on that. If a person is sleep deprived, yes, it helps the person to catch up the lost sleep. So it could be healthy, but it could also be a sign that you are sleep deprived because of any reason. And sleep deprivation can be voluntary, as we see in insufficient sleep syndrome, or it can be because of any kind of sleep disorders like sleep apnea, sleep-related movement disorders like RLS or circadian sleep disorder. So it is not always healthy. Okay. We have to look at the other parts of the picture, that why does a person is napping.
Question by Dr. Imran. What logical combination of medications you would recommend if a patient does not respond to one group of drugs?
Sir, I think in that case, first and foremost, we should try to review the diagnosis. Second issue is we should try to find out if the person is having any other comorbid sleep problem, because nearly 40% of the patients who we consider as having chronic insomnia, they have sleep apnea and they do not respond to any of the medications.
Okay.
Many of the patients, they are having central sleep apnea. Many of the patients, they are having periodic limb movement disorder. Many of them are having comorbid RLS. Many of them are having sleep-related seizures. So if a patient not responding to usual therapy, sir, it is always good that you go for the investigations based on the history and the clinical examination.
Okay. What would be the choice of medication in a patient with vascular dementia with behavioral problems in sleep?
Sir, as of now, if I talk about the scientific literature, it clearly mentions that in the patients with dementia, addition of melatonin helps in improving the sleep. Okay. But the literature does not recommend any other medication.
Sure. Dr. Prasanjit, would you like to ask any questions?
Yes, thank you, Alim. Sir, what is your comment on the cognitive impairment of long-term benzodiazepine use, particularly in the non-demented but elderly males?
Sir, again, the issue is how are we cutting the data, in what doses the person has been given the benzos. And third issue is whether the data that we are collecting, is it clinically meaningful? For example, if a person, if we test, say by Stroop test, and a 2-point difference in the two groups on the Stroop test, is it clinically meaningful? It can be statistically significant, but is it clinically meaningful? So, sir, I think the studies, whatever the studies are available, even the systematic reviews and the meta-analysis, we should try to read them carefully and to find out how much of the clinical implication does it have.
Okay. So there is a question on the timing of melatonin use. What time to take before bed, before sleep?
Usually 2 to 3 hours before the scheduled bedtime. And that scheduled bedtime can vary from one person to other.
Okay. Suppose 8-year child having night terrors for last 1 year. What is the best management therapy, including pharmac?
Sir, if these are the new onset sleep terrors, then I think you need to find out the reason. Sleep terrors, they occur because there is a discontinuity in the sleep. So you need to find out the reasons for the disruption in the sleep. And the most common reasons for the disruption of the sleep are stress, fever, change of the environment, and then the certain sleep disorders like sleep apnea, other medical disorders like blocked nose, adrenal hypertrophy. So these kind of things should be first be looked into, because night terrors usually start by the age of 4 or 5, because that is a time when the brain is developing, and by the age of 13 or 14 they usually disappear because the maturation of the all the brain, the myelination of the brain areas, the cortex is complete.
Okay. Sir, your views on the resistant RLS. Patient has augmentation with pramipexole. Suppose he is not responding, then what?
Change the medication, try ropinirole, and first and foremost,
Sir, usual dose of pramipexole and droperidol there?
Usually, if we talk about the Indian patient, then we should start from with this 0.125, and we should gradually titrate upward to 1.5. And with the ropinirole 0.25, we start with 0.25 and gradually titrate upward to 2 milligram. If there is an augmentation, stop the medication immediately. Try to find out the differential diagnosis for the augmentation. For example, end of dose phenomenon. So these are the factors that we have to look into. Even then you think that there is an augmentation, try to discontinue the medication, keep the patient in the drug-free environment for 2 to 3 months. Look, again assess the severity of the RLS. If it has come down, please again start the either pramipexole or ropinirole, because these two medications are the most effective. Or you can choose to shift to alpha-2 delta ligands like pregabalin and the gabapentin.
Sir, what about use of prazosin?
Not
in the night terrors?
No, prazosin is indicated for the nightmares, but not the
nightmares, sorry.
And that too only in the patients who are having PTSD symptoms.
Okay. Sir, repeat question on what is the dose of melatonin to start? What is the maximum dose and how to stop melatonin?
No scientific data available, so please
your experience, your personal experience.
Yeah.
What is your experience on that?
Melatonin, I do not prescribe very frequently, and one of the reason is that it's a chronobiotic, not a hypnotic. And we do not get many patients who are suffering from circadian rhythm sleep disorder. But the patients who are coming with the delayed sleep-wake phase disorder, we usually prescribe melatonin till 10 milligrams in the gradual incremental doses, and patients, they respond.
So you're saying it won't help much in this insomnia?
Yeah.
Only in the chronobiology it will help.
Yeah.
Okay. Any observation on the suvorexant, the orexin antagonist?
There are meta-analyses which are available which say that suvorexant is a good molecule, but it is not available in India. But shortly, Eisai is coming with lemborexant in India. So we still have to see. Again, the reason is the suvorexant and the lemborexant, they do not exactly target the pathophysiological problems that we see in the insomnia. They target the orexins. And orexin is a modulator between the sleep promoting areas and the wake promoting areas. So these orexin receptor antagonists, they actually work through a different mechanism and indirectly. And there is no head-to-head trial comparing any of these agents with the benzos. Nobody dares to compare itself with benzos because they are most effective medications.
Okay.
Sir, your opinion on mirtazapine low dose?
Sir, again, you can use it, but again, it's a kind of off-label use. We do not have any data regarding the use of mirtazapine for the patients of chronic insomnia alone.
Dr. Prasanjit, would you like to take any questions from the chat box to Dr. Ravi?
Yeah, sure. Now, one question from Dr. Bhabesh is, do benzodiazepines worsen the nightmare?
Well, I really do not know about it, whether it worsens or not. But pharmacologically speaking, it should not, because it will maintain the continuity of the sleep even during the REM period. So it should not.
Dr.
So it
Atul,
increases the proportion of REM.
Yes. Dr. Atul is asking about any good literature on RLS to go through.
Sir, good literature on RLS, maybe I think you can go to the guidelines by the International RLS Study Group. These all are freely available on the Google, so you can download the literature regarding diagnosis as well as short-term management, long-term management, iron therapy, RLS in the pediatric group, RLS in the management of RLS in the pregnancy, and the special group. All these guidelines are available.
One more interesting question, sir. Management of treatment-resistant insomnia. Your thoughts?
Sir, I am yet to come across the term treatment-resistant insomnia. I mean, there is no such term in the scientific literature. That is one thing. Second issue is if the insomnia is resistant to treatment, then again, we have to first review the diagnosis. And history alone will not work. In these patients, you may need to go for the actigraphy. You may need to go for the polysomnography. And then only you will be able to decide whether the person is actually having insomnia or something else.
Dr. Imran is asking about management of excess daytime sleepiness.
Sir, again, the reason is, what is the reason for the excessive daytime sleepiness? It is it the sleep deprivation in the nighttime? Is it because of any sleep disorder? Yes. Is it because of a regular sleep wake schedule? Is it because of any other hypersomnia like Klein-Levin syndrome or idiopathic hypersomnia? So first we need to find out the reason for the same. And based on the diagnosis, yeah, sir.
Yeah, your opinion regarding using stimulants in such cases, like atomoxetine or any other drug?
Sir, I tell you, the basic issue is EDS just is a symptom. Now we have to find out the etiology, and based on that etiology, the treatment will be planned. If it is because of the insufficient sleep syndrome or sleep deprivation at night, why would I use atomoxetine during the day? I would rather ask the patient to have proper sleep, adequate sleep at night. That will cure the condition. If a person is suffering from sleep apnea, I would rather treat the sleep apnea.
If it is narcolepsy, sir?
If it is narcolepsy, in that case, modafinil is the drug of choice for the daytime sleepiness. And for the cataplexy, you can use cataplexy part, you can use SSRIs, and you can use the GHB, which will act on both the parts. Gamma hydroxybutyrate.
Yes.
But unfortunately, GHB is not available in India as of now. So we have to use two different medications. But again, narcolepsy is a very rare kind of diagnosis in India. We don't see narcolepsy in Asian population. The prevalence is much higher in Japanese population for some reasons which are unknown.
Sir, there is one question. Rebound increase in REM sleep following stopping of benzodiazepines.
Yes, it can be there. There is no doubt. But the problem is it really worrisome? If it is clinically significant, then you can restart the benzo and slowly taper it.
Okay.
Okay.
Over to Dr. Yeah,
Yeah.
please.
There is a question, is there any method to stop trazodone, QTPin or doxepin in well-maintained patients?
Sir, would you like to discontinue any medication in a person who
when
has
the patient is
hypertension or
well-maintained.
diabetes?
Yeah. If a patient is well-maintained,
yeah,
then continue.
Continue. And again, the insomnia is a relapsing remitting condition. You can always try some drug holidays. If the symptoms they relapse, you restart. If the symptoms they do not relapse, then discontinue it. Give it a prolong the holiday.
Is there anything that how much percentage dose to be decreased? Any idea?
No, there is no guideline. Again, one has to use his own judgment.
Okay, so you if you want to decrease in very minor
yes
amount. Wait
minor
for some
amount,
time.
or you can go with alternate days.
Yeah.
I mean, first, for example, you are giving 100 milligram of trazodone. Make it 75, then 50, then 25, half a tablet, then make it half a tablet alternate days.
Yeah, that would be a fair thing to do. Tufan sir, any comments from your side?
Thank you, Dr. Gupta. It was a very nice presentation. Two things I was wondering. I do believe that in sleep problems or sleep disorders or sleep problems we face in the clinic, on the basis of my practice over a long period, every patient is specific. And I do attest to the statement that no one should be scared of benzos. There is no human purpose is served by a person allowing him not to sleep for months just to not to give the benzos. It is inhuman. But another thing, what about lullabies? You know that lullabies for. And another major concern which I face in my practice and which many of us must be facing is the profession-related sleep disturbances, the shift duties, and nowadays this computer engineers working through late night because their team members, it is their daytime in foreign countries. So they cannot maintain that what we call the sleep hygiene.
Right.
And that's the
Sir, I think there's a professional hazard that we have to live with.
How to deal with their problems.
Sir,
if a person comes to me, I cannot ask that you have to live with it.
Sir, I think in those cases, we can use the techniques that we use with the shift workers. So we ask the shift workers to recuperate their sleep whenever it is possible and try to be as regular in their own sleep-wake schedule as possible, rather than imposing our sleep-wake schedule on them.
In most of these cases, there is a comorbid psychiatric illness like depression and a common sleep problems to us.
Sir, again, people who are suffering from chronic insomnia or sleep disorders, they often present with symptoms which are suggestive of either somatic symptom disorder or depression. And many of them, we keep on treating them with the antidepressants and they do not improve. So if a person is not improving and having this comorbid sleep problem which are prominent, then I think we should give priority to the diagnosis of sleep problems rather than the psychiatric problems.
Thank you very much. Nice.
Sir, I think we should invite chairpersons for the final comments.
Yeah.
Yeah. Dr. Ravi, sir. Dr. Ravi, can you hear me?
Of course, I can.
Sir, just one small query from my side also, sir. But although almost you have to complete everything, sir, covered everything so nicely, nothing left to be asked, sir. But just and we all know after such a lovely presentation, sir, patients come to our clinic and we tell them all those sleep hygiene, what needs to be done, what needs to be done. But sir, they want a shortcut. Everybody wants a pill to be popped up and it should be taken care in one go. If we keep insisting them, they stop coming to our clinic. They go to the other person who gives them pill. And sir, if they then sir, what needs to be done? That's how to motivate them in this scenario.
Again, you have to spend time with the patient. And again, the issue is, look, these non-pharmacological therapies are not something which we can give. There is actually the problem is with us that we forget the basics of the psychotherapy. When we talk about the basics of psychotherapy, there was a candidature for the psychotherapy. So every person is not the candidate for the non-pharmacological therapies.
Thank you, sir. Thank you very much. Now, before my final comments, sir, I would like to thank you, for Dr. Ravi, for presenting such a lovely presentation. It was really enlightening, and it was a feast to hear you, sir, as always. I'm really thankful for enlightening us and increasing our knowledge to a different level. And thank you all the organizers for having me and such a lovely presentation and program. Thank you very much. Over to you, Dr. Prasenjit, sir. Please, sir.
Thank you. My sincere regards to Dr. Tufan Pati, sir, and my dear friend, Dr. Alim, for inviting me here. And it was a very nice, interactive, highly interactive session. Thank you, Dr. Ravi, sir. What I can summarize is that management of insomnia has to be customized for every individual. And sleep hygiene is complementary to pharmacotherapy. And while choosing benzodiazepine, one has to be careful that there might be some subset of population who might have some problem, but one should not hesitate to use benzodiazepine using a good clinical skill or judgment. Over to Dr. Alim. Thank you.
Thank you, both the chairpersons. Tufan Pati, sir, your final comment, and then we can close the meeting.
Thank you very much. I shall do the formal duty which IPS OSP does. This is to thank our speaker, Dr. Ravi Gupta, the chairpersons, Dr. Prasenjit Ghosh and Dr. Pankaj Kumar, and the vibrant moderators, Alim Siddiqui and Amrit in absence, and our support staff, our supporters, Current Lab, Rohit today, and in all the days, there is Pawan with us, and Shajia, etc., who are the think tanks. All of them, I convey my hearty gratitude who have been with us for the long journey, and wish that they will be with us for all times to come. And we go with some understanding, sleep problem, major problem, and every patient has to be dealt separately. And in the management, which I strongly believe that benzos have their role, and patient education and patient participation is very important. So with this, I thank for this illustrious lecture to Dr. Ravi Gupta. Thank you very much, Dr.
Pleasure is all mine, sir, and thank you very much for this opportunity.
Thank you so much, Ravi boss. And sir, let me add that our insomnia course by IPS and WPA has got 18 CPDA points, and Dr. Ravi Gupta is the course director. He is our course director of the sleep short sleep course that we'll be launching. So, Sir Ravi sir, thank you so much. It was a very lucid presentation. Some new things actually came up. Some are still, I think we need one more session sometime. So, thank you so much, Ravi sir. Tufan Pati sir.
May I take 1 minute before we close, Rohit? I take this opportunity to invite everyone to join live the Indian Institute of Pediatric Mental Health CME program that will be on 27th and 28th. There are good faculties, and we are having the program. I have shared the link with many groups as well as EIPS. So sharing with the all IPS members also. Please do attend. Thank you. Now.
Thank you, sir.